our world needs us. It needs all of us to pay attention, to plug in, to commit, to tap into the powerful network of minds, ideas, and possibilities that are gathered right here. Because the stakes are higher than ever. Food insecurity, climate change, access to healthcare. These are the critical issues technology has the power to solve. The kind of tech that is already emerging around us, impacting every industry, every city, and every home. But these aren't just exciting new technologies we're talking about. These are solutions, powerful innovations, and most of all, hope. We're hopeful because the moments we spend right here might be some of the most important moments of the year. This is a chain reaction that begins now and affects everything, from the sustainability of this world to the exploration of others. Yes, the tech we'll see at CES will impress and astound us. It will also motivate us to innovate our way to a healthier, more sustainable world. But this kind of transformation requires our full attention, everything we've got. So be ready, be engaged, be inspired, be in it.
Please join us in welcoming Kenzie Fabrizio to the stage.
Good afternoon and welcome, everyone. I'm Kenzie Fabrizio, Senior Vice President of Membership, CES Sales and Marketing for the Consumer Technology Association. And I'm really excited to introduce this panel. The digital health category is absolutely one of my favorites, and we have a wonderful session for you today. For years, CES has been at the forefront of digital health. We have been showcasing the latest and greatest innovations that are reshaping the industry and the approach to health and healthcare. And we believe that at its core, digital health is about empowerment and engagement. Advances in telehealth, wearables, remote patient monitoring are giving consumers more autonomy and influence over their personal health. And these innovations help keep doctors more closely connected to their patients. To tell us more about how tech is shaping the future of healthcare here in the United States, I'd like to welcome our moderator for today's session, Dr. Carlos Nunez, Chief Medical Officer of ResMed. Prior to joining ResMed, Carlos was Senior Vice President of Medical Affairs at Becton Dickinson, and he held senior roles at CareFusion and Pisces. As his title suggests, Carlos started his career as a physician, working as a practicing anesthesiologist, intensivist, and hospitalist. That's a lot of ist, Carlos. And held many other senior roles. With his impressive background, I'm sure you'd agree that there is no one better suited to moderate this session. So please join me in welcoming Dr. Carlos Nunez to the stage.
No, I'll make a joke about it. It's like a game. Which one is Carlos? That'd be me. Hi, everybody, and welcome. And thank you all for making the time to come here. This is an extremely exciting panel and an extremely exciting conversation that we're about to have. And when I introduce the rest of the panelists, you will probably understand why. So I will start all the way on the far end. That is Dr. I gotta take my glasses off because I can't see with my glasses on. Dr. Susan Turney, the CEO of Marshfield Clinic Health System. Next to her, Dr. Stephen Klasko, the executive in residence at General Catalyst and formerly the president and CEO of Thomas Jefferson University and Jefferson Health. Thank you. Next to him is Dr. Vidya Raman Tangela. I hope I did that good.
Perfect.
All right. Chief Medical Officer of Teladoc Health. And right next to me, Dr. Ann Dosimo, the Chief Medical Officer at United Health. That's what I get for going in that order and not the order that I wrote it down. So thank you all for being here and welcome. And as you know, we are going to talk about the future of healthcare in America, a new hybrid model. And we don't mean that we're going to buy Priuses for all the doctors and nurses in the healthcare system. What it means is we're building something new in healthcare, not just in the United States, but across the world. We have a system that's been working as it has for many decades. But we have forces at play that are pulling our healthcare system into the future, accelerated and catalyzed by the pandemic that we are hopefully trying to emerge from and understanding how to live with. And so what I'm going to do is ask every one of the panelists to first give what their 2-minute impression of what is this new hybrid model, or what does the future of healthcare look like to them. And before I start, I just want to say one thing. Dr. Klasko and I were chatting backstage before, and he mentioned something that was quite interesting. 5 or 10 years ago, you'd have the leaders of healthcare systems talking about this stuff amongst themselves. You'd have the leaders of insurance companies and other payers trying to figure solutions out for problems, or members of industry trying to do things on their own. Now, they're all sitting on this stage trying to answer these questions together. And if you walk through the North Hall here and you look at all the health technology, what strikes me is that there are a lot of partnerships. There's a lot of collaboration. There was a physician tour through that area just a few minutes ago before this session, and there were members of the FDA, practicing physicians, people in industry, all together trying to understand how technology is going to change what we do when we practice medicine and deliver healthcare. So let's start all the way on the end. And Susan, what do you think a hybrid or the future of healthcare looks like?
You know, the changes in healthcare over the last couple of years have accelerated at a pace I don't think many of us ever thought was possible. When I think being in a large integrated health system and having many of the tools for 25, 30 years that we never really utilized. We had telehealth, we had remote care, we had access, because we are an integrated system, to both health plan and care delivery data. We never fully utilized it. And I think we finally came to the point that we realized it was easier to adopt these tools and use them in an efficient manner. We also realized that the patient was right smack dab in the middle of it and was more than willing to change the way they sought care, the way they accessed care, and it has allowed us, during a time of tremendous turmoil in our country, to really start to think about what does it mean to have equitable care in the United States, and how can we use the innovation and the technology tools to make that happen. And I'm glad the acceleration took place. I'm not so happy about the reasons why it occurred, but I think it's a great time for our communities. We're very rural. We serve 1.5 million people in geography that's very rural. We have 65,000 square miles, and our biggest community is 50,000 people, even though we have 1,400 clinicians and a lot of miles and roads between the ability for people to get seen for care. So when we think about equity and the use of tools, we know that our communities will be better off because we've now really accelerated that pace.
Stephen.
Well, Carlos, I think, look, the first thing we have to recognize is that American healthcare needs more than a tweak. I was on a panel with Sebastian Thrun, and he said the problem in American healthcare isn't that we aim too high and fail, it's that we aim too low and exactly hit the mark. And you know, I think that if you look at the pandemic, and it's not any of our fault, it's the system. We all did heroic things. But the fact that people in Philadelphia, which is the home of Comcast, literally, that there were zip codes that less than 50% had broadband. And the fact that literally they were told on CNN not to go to the hospital in August 2020 because they get COVID, and they had chest pain, and their partner or wife, husband might have said, why don't you go to sleep, honey, because you can't go to the hospital, and they died. And the fact that, you know, literally, you know, in an insurance case, that might have been positive to the bottom line, in the hospital's case, negative to the bottom line, that makes no sense. So how we redefine ourselves in a radical collaboration way is, to me, what the hybrid model is all about. I built a health system, and Ann was part of building that went from 2 hospitals to 18 hospitals. From a 197-year-old health science university merging with the #3 design university around design of the human experience in healthcare. If you came to my office in December 2021, it had a sign that said, I hope that when Elon Musk brings people from Mars to Philadelphia 5 years from now, and they ask, where's Jefferson? You can't define that. Do you mean Jefferson at home, or Jefferson our partnership with United, or Jefferson, with Comcast? Oh, you mean the place where really, really, really sick people go? I think that's still a tenth of walnut. The fact that we define hospitals by where we failed to keep people healthy is partly what's wrong. So, I guess, I'm the oldest person on this panel, and I've been doing this for so long, and I hope, as you said, that getting these kind of folks together, we really are on a different nexus and plane, right? There was a Jason Kidd quote when he went to the Dallas Mavericks. They were 24 and 52, and he was at the press conference, said, I'm going to turn this team around 360 degrees. We do a lot of turning things around 360 degrees after conferences. So I'm hoping that this kind of a panel at CES and others really start that consumer revolution in a very different way. Last thing I'll say is, Harris Poll just did a thing, and 3 or 4 things that were just so indicting, but one is that 62% of consumers felt that we intentionally make healthcare complicated to prevent them from getting care. Now, we're not that smart, unfortunately. It's just an accident. But I think those are the kind of things that we really have to fundamentally transform.
Thank you. Vidya?
Yeah, I would just build on both of those points. I think what the pandemic did was help raise awareness about the role of technology in healthcare. And I'm talking at the common man consumer level. So that part's done. But it also woke us all up to the truth that the mind and the body and the context with which we live in, they're all connected, right? So to me, the future is really about how do you go from virtual care or technology-based care, meeting an urgent situation, to really addressing holistic, whole person care, combined with, and I think I'm also a big believer that just because there's a lot of technology, the build it and then they'll come model doesn't work. So we have an opportunity, we have a responsibility to translate the value of technology and technology-enabled solutions to people so that we educate them. We see this all day, every day, right? If there's a fear of technology, if there's a lack of understanding of technology, you're not going to get the uptake. And those of us sitting here and in the room know that if people do leverage technology and data, they can actually do so many things on their own, improve chronic conditions, seek primary care when they don't have other access, and so on and so forth. So I think we have a fundamental responsibility to bring people along, educate them, make them feel comfortable, and to the point that you were alluding to, let's not recreate the bad things that we have today. Let's create new value. Let's close gaps. Let's create new value. Let's exceed consumer expectations.
Ann, what do you think?
I think all of that and more. So I will, taking it from the payer perspective, United Healthcare, obviously the pandemic was remarkable. As many of the health systems were trying to provide services, so were payers. And we were trying to provide those services for the people who didn't want to go into the hospital. And obviously telemedicine became the way. So we actually had many actually virtual conferences teaching our providers how to use their electronic records that they had, leverage telemedicine services that are in our network, and to be able to get care that they needed. And then, of course, things became more convenient for them. They could do a COVID test at home, and they could do other things where they could get the care and augment that televisit. So a lot of those things happened, and quickly things turned around, and we saw, obviously, telemedicine visits skyrocketing. So telemedicine has come down from the height of the pandemic. Now we're at 1,700% higher than pre-pandemic, and that's our new normal. And 95% of those telemedicine visits are with local providers, with the care providers that that patients would normally go to, but they're seeking to do their care virtually as opposed to in person. And so we used to talk about medical home about 10 years ago. People are like, I don't want a medical home. I have a home. I'd like to stay here. I'd like to get my care here. So, about those are 95% of the visits are with their local doctor, but they're about over half of the behavioral health care is now virtual. Over half of that's virtual. And the amount of it, when you're saying the stress and the anxiety, that really obviously I think became also at pandemic levels recently and epidemic levels, really overwhelming the system. Even a system like United Healthcare, where we have a network of 340,000 providers and facilities. Even our network is overwhelmed, and we increased the size of the network, adding a lot of telemedicine services. And during that time, year over year, from 19 to 20, we increased the behavioral health visits by 10%, 20 to 21, another 17%. So the demand is out there, and as we go around and you see so many of the apps here, you'll see so many behavioral health care apps, so many sleep apps, so many apps for stress. And those are things that we're seeing here as well, not only in the healthcare space, but in the wellness space, in the self-care space. And I think that's, when we're talking about personalized medicine, it's not all about the genome, it's sometimes patient preference. So I think we'll see a lot more of that as well.
Yeah. Carlos, just one other thing. Because we have so many people in the audience that come from the consumer world, etc., one of the things that I believe hybrid care will bring is a much better job of consumer segmentation. It makes my brain explode when I see a billboard that says, Pleasantville General Hospital, we are patient-centered. Or are you patient-centered for a 68-year-old with an Oura Ring and an Apple Watch, or a 28-year-old disconnected person, or a 75-year-old woman with cancer that only goes on Facebook to see her grandkids? So the question is, how do we start to take advantage of some of that personalized care and population health, right? My son's an actor. He did a Love's diaper commercial. I made the mistake of watching it 5 times on YouTube. And now every time I go on Google, I get, hey, Steve, are you having another baby? Do you need diapers? We should think about that if I have lupus, that, those same kind of things are happening for my healthcare provider.
Well, Anne alluded to something about personalized medicine, what you're talking about. It is not all about the genome. There are companies like Google, the owner of YouTube, that have shown if you collect enough data about someone, even if it's messy, you learn a lot about them. And so we have a unique opportunity. So let's talk about technology. You may have noticed this conference has a little bit to do about technology, right? And we talked about telemedicine and personalized medicine, the medical home. But what we are seeing is, there's a reason why CTA is becoming this convener and this center of attention for digital health. The consumers' expectations of technology are exactly what their expectations are of healthcare technology. They're wondering why it doesn't work as well as this app that I have, or it's not as engaging as this app that I have when I pull up the app for my doctor's office or for the pharmacy. So what can we do in technology to make people feel like healthcare works as well as all the rest of the tech that surrounds their lives? We'll start with you and then go in the other direction. How's that?
Give me the easy question.
Yes.
Okay, so it is so complicated because it's so fragmented. There's data everywhere, and that's the problem. The data is everywhere. It's fragmented, it's in silos, and unlike, everyone always say, well, look, finance can do it and banks can do it. They had the advantage that the data was already digitized. It was already all numbers. We have so many words and so many complex concepts, and we have it in claims data, in codes, we have it in text. It's, it's just in every field, even if we were just to talk about heart failure and, 4 stages of congestive heart failure and what are they and how you would treat them, everything the complexity just gets exponential. And when you look at the underlying platforms, they're all different. They have different ontologies, different data maps. So what we have to get to is a common platform where we can unify that data so that person can have that uniform experience. In some places, we're making a lot of progress, like with medications and labs, vital signs even. But there's still a ton of text-based data that's really hard to configure. And if somebody gets labeled with a diagnosis like Alzheimer's because someone thought they were confused and then they give them a diagnosis, that stays with them forever. And so I think we have to really, that has to really catch up, I think, for us to really leapfrog ahead.
Yeah, that's a good point. And our friends at Intel were involved in one of the best member benefits of CTA. They have these Focus Fridays, and they did a great presentation. And Intel was one of the presenters a few months ago, and they said, Healthcare data is 1/3 of the data generated in the world every single day, and more than 90% of it sits unused. It's only about 5% that's used for generating insights. It's incredible, the untapped potential there. Yeah, what do you think?
I'd pick up on exactly that. I think we have more data than we know what to do with, right? And if we sitting inside various organizations and as an ecosystem are struggling to make sense of the data, how do we let people, how can we expect them to do any better? So I personally think that, going back to my previous point, we need to show people the value of the data that they are willing to give us. I find that it's very difficult to just ask people to share their data without really saying, guess what, this is what we can do for you. So take something as simple as food logging, right? We can ask people all day long to share the food logging data and activity data with us, but how cool would it be to maybe on at least a weekly basis say, hey, did you know you tend to trip up on Thursdays? Something in your schedule, so you may want to be more mindful. That's all. You just passed along a very relevant piece of insight. So I think your bigger question about, what do people want? I think it's that personalization. They certainly don't want the choppiness that exists across the multiple apps and multiple websites that they have to go to today. They want everything unified, to steal your word, have one uniform experience and have all of these services that are relevant to them be available under one umbrella, but that it should be personalized. We heard at Teladoc Health from so many members that and we see that in our data. The ones who engage the most and the ones for whom we see the best outcomes are the ones that feel very understood. They felt listened to and they built that relationship. And so, and the only way we could do that was by using data. So we put data to use to not just to bring people in, but to engage them, which happens to be an ongoing journey. So today I said the right thing, I got Anne on my side, but 3 weeks later I may need to know what I need to tweak with her. So putting data to use to drive insights that are much more personalized, that are very relevant. And I'd also add, it's not just clinical and the data that we have, but it's social determinants, which are a huge component. And we find that when we address everything holistically and not in a choppy manner and really provide value, we see better engagement and that drives better outcomes. So.
Stephen?
Yeah, look, I think we've been talking about data for a long time, and it's not, as Ann said, it's not about data, it's about actionable data. And, but the big T when it comes to data is not technology. The big T when it comes to data is trust. And I think that's been the biggest problem, frankly, because, it's basically patients do not trust anyone other than, their physician or nurse, and in some cases their payer. So I did a survey of some of the folks that had been in systems that partnered with some of the for-profit big techs. And one of the things that the patients told me is, I'm not telling the truth if I know that my health system has a deal with, Amazon or Google. What do you mean you're not telling the truth? Well, I'm not going to say I had an abortion, because what if I'm not going to say that I drink every day, where I might have told my family doc I'm a social drinker. Well, how often do you drink? I drink every day. Well, that's not exactly a social drinker, right? So we have to figure out how to get that trust piece. The second problem, and that was brought up by both of you, is fragmentation. Fragmentation in a lot of ways. It's not just point solutions, right? We don't get up in the morning and say, I think I'm going to telebank. It's just that 90% of banking went from being inconveniently at the bank to conveniently at the home. And I'm a fellow of the World Economic Forum, and the head of one of the global banking companies said in 2020, right before the pandemic in Davos, 40 years ago, the two sectors that escaped the consumer revolution were banking and healthcare. And he took a sip of his coffee, said, now you're alone. And when we talked about that, it wasn't just the technology, it was the emphasis on the consumer. The other piece of fragmentation that I think we've intimated here is, who's benefiting from that data, right? At General Catalyst, we're looking at a public benefit company that's taking blockchain tokenization and DAO, so that when you, Eli Lilly, or somebody gets my data and uses it for clinical trial, some of the benefit will go back to me. through that kind of tokenization piece. How do we get out of a situation where I'm just going to HIMSS or CES and having 840 28-year-olds say, buy my data solution and it'll transform healthcare? So we got to get through that fragmentation. And the third thing, which I think is really, really, really important, is data is not just sick care data, and I think you brought it up very well. It's how do we start to use natural language processing and other technologies to get at that 80% of a person's world that affects their health. I had one patient 19 times into our ER with asthma, okay? We had every specialist looking, why would you come 9 times? Turns out she had a lot of mold in her house that the community health worker told us. And I would have been better off getting a handyman or handywoman to come to the house to do that. If I had that data around their housing and their food, et cetera, we'd have a much better healthcare system.
Susan, we'll give you the last word on this one. And I can imagine technology, data, all of these things in a rural area, it's a lot of opportunity there, but probably difficult with things like broadband access and all of that.
A couple of things that have been said here, but trust is really important. If we erode the trust of our patients, our families, and our communities because of the use or misuse of the data, it's really hard to recover from. So we have to be very careful in how we use the information and be very transparent about the purpose. What is the why for why we're using the information? But I think, we have the technology to collect the data. We have a lot of power to analyze the information, and we do that. But when you find something, as Steve said, who benefits? And every time we implement a process, there's an infrastructure that has to be created, and oftentimes it involves people to manage. And as something as simple as a congestive heart failure improvement clinic, we can identify all of our congestive heart failure patients. That's not very challenging. We can also make sure we have all their metrics, and they can continue to feed that data to us from home on a regular basis. But then you have to have the people that are going to manage it, and you have to have the infrastructure to make that happen. And oftentimes, there aren't resources for that type of work, because that's not how the healthcare system financing models necessarily work. So that's just one example where it's the right thing to do, and really everyone benefits. The patients have better outcomes. The families are happier because their family members not in the emergency room or in the hospital being managed. The payer, we are a provider-based health plan as well, and do better because there's less admissions, readmissions, emergency room visits. But there's that whole process that has to be built. And I don't think we oftentimes take those next steps. But even a more, not probably outrageous example, but we collect a lot of information on social determinants. So now we know that we have a large population. About 1 out of 4 or 5 kids in our households have food insecurity. They are not getting meals at home. So they get their meals at school twice a day. And then we figure out ways to help them at times when they're not able to eat. But now that we have identified it, whose responsibility is it? How do we engage our communities to be partners so that we can fix the situation? Excuse me, being in rural Wisconsin and many of our communities, which are mostly under 2,000 people, there's a national chain that has a, sort of what I would consider small box stores where they do provide food, but the food is all packaged goods. So happy to say that they have now realized that the food insecurity is so great and people can't use this as an alternative. It is the only option for their food source, that having fresh produce in that store is extremely important for the health and well-being of that community. So I think the data is great, but where can you have the most impact? Who is it going to benefit? And how are you going to make the necessary changes within the healthcare infrastructure, but the community as well, to make that happen? And you pointed out that we're rural. We work with over 400, probably more, but at least 400 different agencies to extend our care outside of our 4 walls. And these are agencies that operate on a shoestring as well. Most of the businesses in our communities are small businesses. People who work there don't have paid time off. So there are many, many socioeconomic struggles that we have that make it, even more challenging to make the impact that we know we can. We know we have the data. We know we have the ability to intellectualize it. It's just making sure that we actually follow through and, really meet our mission.
Great points. Yeah, data is central to so much of how technology will help us improve healthcare. But as you all pointed out, we are struggling. I mean, healthcare is struggling to, we are left behind. Like you said, the finance industry finally made it, and we are still a little bit behind. But I think what we can do with that gap of time is learn from, the things that those have come before us who maybe stumbled some, and we can. It's like the analogy or the metaphor. I'm sorry, the analogy of putting in landlines in rural parts of the world, just going straight to cellular. Why bother stringing up phone lines? So we have the chance to kind of leapfrog and learn from the mistakes of the past. And I think one of the areas where digital health holds a lot of promise is in closing gaps in access and in providing more health equity. So Vijay, we'll start with you, and we'll go in that direction and then come back this way.
I see the pattern.
Yeah, I'm mixing it up. Think about, technology. You work in industry now. A physician working in industry for a technology company. How do you think that technology and digital health can close gaps in access to care, can make care more equitable?
Yeah. Again, much like what's been said, I think even in the context of health equity, I'd offer that just because there's technology doesn't mean it's going to close the divide. It's going to bring about health equity. We have work to do. There was a recent expose which basically showed that two neighborhoods separated by less than half a mile, families paid the same monthly amount for internet access, and the ones in the higher income neighborhood had much faster speeds, whereas these ones had like 20 times or 30 times less fast speed, so really slow speed. This was a recent expose, and so it's just shocking that this is what's happening, and then here we are saying, well, yeah, we've made broadband and we've made technology accessible. If it is not usable, if it's not affordable, then I think we've failed. That's one. And I think when it comes to the work that we have to do in positioning technology and everything that it can do to bring about health equity, I think first and foremost is actionable data, like you all said, right? How do we know who we are serving? How are we doing in serving them? What's working, what's not working, right? And so, for instance, within our organization, we've actually had to create a new a standard data set to understand these elements around health equity, and we're painstakingly benchmarking, and we'll continue to do this, everything that we do against that standard to see how. So we need to know what we're doing right and what we're not doing right. Access is the, like you brought up, it's one thing to have access, whole another thing to have affordable access. And access is a function of many things, right? It's geography, it's technology, socioeconomic status. So you've got to understand what drives. And then we're also finding that there are people who actually have the access but just won't leverage it. So why is that the case, right? So how do you close that gap? That's an interesting one too. Understanding how you provide a very unique experience. So now you have technology and you're trying to bring about equity, but can we understand the person? Can we put the data to use so that we really know who we're talking to and give them that unique experience, and then continue to focus on outcomes? So we're doing all of this and more, and I think it's also about, again, many of us are technology companies or service companies, or you may be a health system, asking yourself if your products and services inherently or maybe inadvertently bringing about biases. So for instance, algorithms that come with bias, right? We had this discussion about the pulse oximeter this morning, right? So that's another one. How do you make sure that devices are not doing something that they're not meant to do? How do you get, look at your people and say, do the people look like whom we're trying to serve? Is there enough disparity and diversity on this, on the provider side of the equation, so that people can build that trust and, actually work on outcomes? Looking at partnerships, I'm a very big believer. This is not a one company job. This is like, it's going to take a village, it's going to take the ecosystem. So partnerships, policies, everything. So yes, there's technology. Yes, we can focus on health equity, but I think we have to come at it through all of these angles, really humanize it.
So I love that you asked this question, because I think we have to figure out how we take population health, social determinants, and health equity from this philosophic and academic exercise to the mainstream of clinical care and payment models. People are still getting grants to determine whether or not there's a 20-year difference in life expectancy in Philadelphia or a 25-year difference in life expectancy. I mean, we have to be over that. So, you know, I start out by saying we can't do tweaks to the system. We need to be radical collaboration, radical communication, radical concentration on health disparities. On the radical collaboration side, and you know, it's so great that people like Ann have moved from the health provider system to the health payer system because they get both sides. But I think Upton Sinclair said it's hard to get somebody to do something when their salary depends upon them not doing it. And there's so much of that in healthcare, right? So I'm a high-risk obstetrician. We spend 4 times more per obstetric patient than any country in the world. So we must have the best maternal outcomes, right? Wrong. We're somewhere between 25 and 30th, somewhere between Serbia and Croatia. Well, why is that? Well, we have totally messed up incentives, right? I mean, we have very high NICU admissions, et cetera, and the hospitals make a lot of money by having people come to NICU. Everything is come to the hospital. I was on the board of a company out of Israel that was doing remote obstetric monitoring. They couldn't get that started in the United States because the hospitals make a lot of money from having people come to the hospital to get that monitoring. My daughter got pregnant during the pandemic, and she said, Dad, I had to go 3 times a week to get a non-stress test. $35 to park 3 times a week, go to a place where there are a whole lot of sick people, so I could go up in an elevator, somebody stuck a monitor, I stared at the ceiling and told me I was okay. I thought you were the digital dude, can't you take care of that? So at the end of the day, why can't we take care of that? Why? Because hospitals make money, because there's malpractice attorneys, that the first patient that I did a remote obstetric monitoring in that didn't get into Princeton 16 years from now, you know, we'd be sued. So we have some issues in our system that are wrong. On the technology side, I think the good news about both health systems recognizing that they can't make it anymore just by taking care of sick people, and even in your world, in my world in GC, of our founders recognizing you can't just put AI in your title anymore, you know, and have a $2 billion company, that it's forcing us to start to talk together at a different way. I was just doing an interview here at CES for a company I've been working with, Stell Life. That's one of the leading companies in bringing some of the things that you need for healthcare at home out to the home. But they recognize that's just part of the whole Lego system of the Internet of You and the Internet of Things. So how we start to get Teladoc together with other companies, so it's not, okay, I'm doing Teladoc for telehealth, I'm doing this, and then how we start to recognize, and I think you've made this point, that an underserved person in North Philadelphia might need a different level of education, the things that are going to be important to them are different. Getting back to my daughter, it might have been a pain for her to have to pay $35 to park 3 times a week, but if I was an essential health worker, I couldn't afford a nanny, I just wasn't getting those non-stress tests, and I was going to end up with a patient in the NICU, which means the insurer's paying a whole lot more money, and the hospital's making a whole lot more money. That fragmentation of who makes the money just makes no sense.
Susan, what are your thoughts?
Yeah, thank you for that, those comments. We kind of started on what is access and how can we improve whatever that means. Because I think access can mean something as simple as being able to appoint with a clinician and the challenges of waiting oftentimes weeks to actually get in to be seen because of all the inefficiencies that occur within the healthcare system as it exists today and the cost that results from those inefficiencies. But, you know, some things that I think are important is that technology has played a big role. If you think about the predictive analytics and the machine learning, the opportunity to identify patients at high risk that are not likely to come for their appointment. And a missed appointment is a lost opportunity. So knowing that we can provide an outreach to those patients so that they're aware of their appointment and the importance of them coming in to be seen and connecting with family members so they can make that happen. But access is also dependent on the ability for them to get transportation. And there may be some in this room, but probably not many, that live in communities where there's no Uber, There's no lift, there's no public transportation, buses or taxis. So people are very dependent on their families to get them to their appointments. So making access available through other venues, through telehealth is just one opportunity, but also remote care. We work with Dispatch Health. We are the first rural system to do that, where they actually do high acuity visits in the home to really, again, identify the patients at risk, make sure that they're getting the care that they need at home. And it's not home health care, it's really medical care that's being delivered within the home. And another thing that we've had to deal with, and many have, but when you talk about access, hospitalizations are devastating to families for a multitude of reasons, notwithstanding the fact that their loved one is in the hospital and needs to be taken care of. People are oftentimes traveling 2 or 3 hours to make sure that, to come and visit their loved ones, make sure that they're getting the care, and then bringing them back and forth for their appointments. So being able to offer hospital at home, which we started over, 5 or 6 years ago now, when one of our major teaching hospitals was going to close, we realized that that created a huge opportunity, and we were able to start collecting the data at the beginning of the start of the program. So we know what works, we know what doesn't work, we know what the needs are, and how that has changed since we've added pretty much any type of diagnoses for treatment at home. We started with 5 or 6 diagnoses just to make sure that everything was ironed out, and found out that patients love it, families love it, the clinicians love it, and people actually have better outcome. And when you talk about who benefits, everyone again benefits, including the plans, because they're paying less for the care that's being provided in a hospital at home setting. So again, using the data to really leverage the journey of care, I think, is extremely important in thinking about the multiple ways that people need access. The good news is that we're in an area where there aren't a lot of disruptors, because it's hard for some primary care company to come in, and when there are no primary care docs to bring into their company to actually help provide care. So we have had to be very innovative in the way that we think about the way we do our work, and again, augmenting all of it with the tools that almost always involve technology. There's no way we could get by without it. But talking about landlines, about 15% of our service area still does not have broadband access. So again, another access issue, and who is responsible for making sure that that ability exists? So
Isn't that a health policy issue? I mean, shouldn't broadband be like electricity or plumbing?
It
like
should
it is
be.
in Singapore and other countries?
So, but, so we are helping to support that, but we can't be that sole source. We don't have all the resources to be able to do that, but it's so necessary, and it is a utility. So again,
It's part
just
of the infrastructure bill.
thinking positively about what you can do for your communities, and a lot of this doesn't require, it's innovative, but not the big I, it's little I. It's doing what's right for the patients.
There's some other stats that I'd share, that Susan brought up. In our population, we find that 60% of people who enroll in our primary care program have never had a PCP before, and they would never have had one. Including about 42% of Medicare Advantage members would never have sought the care if it weren't for this. So how do we find more of them, right? I mean, and then if you think of people managing not one, not two, but multiple chronic conditions, as well as mental health and so on and so forth, to be able to provide that ongoing, almost daily kind of a support so that they are empowered to do the right thing. I mean, those are all gaps that exist today, and every one of us wants to close. So speaking of mental health, I think nationally, 38% of the US population lives in counties and places where there is a severe shortage of professionals in mental health, right? And so 55 to 60% of people don't even receive the care that they're supposed to receive. I mean, these are staggering statistics. You can't even, how do you begin to unravel? How do you start to, make a difference? So talking about hybrid care, it's that combination, right? So how do you know who is who, and kind of make sure that they get what they need at the right time.
Some of that gets back to the payment models, though, right? I mean, the average orthopedic surgeon in Philadelphia makes about $3 million a year. The average family practitioner makes about $250,000 a year. So when Ann started our accountable care organization in Philadelphia, and we said, good news, family medicine docs, you get to be the quarterback for the system. They sort of said, well, wait, you pay me like the kicker, like you're paying the dermatologists and the neurosurgeons and the orthopedic surgeons like the quarterback. So some of that access issue is that we just have to rethink the whole, what the value of a telehealth visit is, what the value of a nurse practitioner is, what the value of a primary care physician is, what the value of a specialist is in a very different way.
Well, I think that's really true. And I think I've had the advantage of working. I started as a founding medical CMO for UPMC, University of Pittsburgh Medical Center, health plan in Philadelphia. It started at 200,000 lives, grew to 5 million. And I think the interesting part there is it really is an integrated delivery and financing system. So the boss, Jeffrey Romoff, figured out you don't want to spend more in your health plan. You're only going to get that as your premium. So you need to design the health system like you've done in Marshfield to really deliver the services that are needed and not more than the services that are needed. So interestingly, in Pittsburgh, that was, while I was there, we closed at least 3 hospitals and others shrunk because you didn't need as much hospital care. And so you don't want to be paying for hospital beds that you don't need. And a lot of the other care was done in the community. At United Healthcare, I'm now solely on the payer side. We've designed benefit plans that are geared to become affordable because you can't get access if it's not affordable. So of course we have plans in all lines of business, Medicare, Medicaid, commercial, and individual. But for a smaller group, employers that are looking obviously to provide benefits, there'll be plans that are specifically designed. It's called Surest, and it's a benefit plan where there's no deductible, and there's an intuitive app that shows where your gaps are. And if you think you need care, it'll tell you what you need for your preventive care, what you should have, and then it will show you where you can go because it's a curated network, and the app will provide direction, and you will be able to choose. You'll know upfront what your cost will be when you go there for your care. And it's remarkable how people make those choices. I mean, we talk about if we had that transparency, and it's hard to do across a national network with a large employer group. But with smaller employer groups, we're starting out having this really curated experience. People will choose 26% less time to have a procedure in an inpatient or a hospital setting versus ambulatory. They'll 6% less ED visits, and 83% of the time they choose the more affordable. So they're really improving access for people where the employer groups may be deciding if they're really going to offer insurance or send you out to the exchange. So I think, that's one thing that we're doing, but other things that we're doing are providing reimbursement for care in all of these places. We have hospital at home. We have tremendous home care, as you know. Clearly, we partner with Optum, and they provide a tremendous amount of care delivery services, and they're at risk for the total cost of care for many of our lives. We also have large ACOs that we contract with. About 20% of our lives are in value-based care contracts, where the incentives are aligned. That's in addition to the lives at risk with the provider organizations. And then those organizations, that's the part where if you are an employee, maybe only 50% of the employed population will even use their benefit in a year. So if I'm the physician, I'm waiting for you to come into me. That's the traditional model. If you didn't show up, no one's managing your care. But you might have been going to the ER, you might have been going to the hospital, you might have been going directly to the specialist. But now we're partnering with them, and we can provide them the data and the tools and the resources. They'll know, here are your 1,000 patients. Make sure that they come in for visits. And we even did that in the ACO in Philly, in our MSSP. We would make sure that all of our members got in for their annual wellness visits, all of our Medicare members. So those are the sorts of things when you start doing population health. I think that's the hard part, is to make that pivot happen. Still today, 90% of care is fee-for-service. 90, more than that maybe. Even in Marshfield, it's probably more than half of your care is fee-for-service. So I think that's a big issue, because that's where the incentive models make it very difficult to keep care affordable and accessible.
So have you noticed what has happened? Every question starts with technology of some sort.
And ends with data model.
And ends up talking about all of the inertia in healthcare that has made it so difficult for healthcare to become truly digital. So I'm looking at the clock. We have about 12 minutes, and I do want to leave some time for questions. We have microphones here in the room so people can stand up. But I do want one last question, and we're going to try our best to stay as techie and nerdy and as geeky as we can. If there's one piece of technology that you've come across, whether it's today walking around or over the last few years, that you think will have a profound impact on healthcare, tell us what it is, and we'll start on the far end and go this way, and with Susan.
Well, that's really a tough question. I would say probably the thing for us in healthcare that I think has had the most profound change and will continue to be impactful is really the data. There are so many tools that we could use if we could only figure out how to get the money to put them in place and the people to implement them and integrate with everything else we have going on. But I think that the data is really going to be the most powerful. And of course, that can't occur without technology and the analytics that have to go with it.
I think food technology and food distribution technology. We had done this thing with the Biden-Harris team that we felt we could eliminate food deserts through technology. Food deserts exist because, Ann and I lived very close to each other. We could walk to a Whole Foods and a Trader Joe's. But there's 5 or 8 zip codes where the only place they can walk to get food is a bodega selling Fritos and Cokes. What if everything's barcoded? What if we told people in those zip codes that if you give your family healthy food, we'll give you 20% more government food assistance, and we'll drone deliver it. So, I worked with a company called Zipline that was drone delivering food, actually in some rural areas. And so, when you think about how important food is as a social determinant, that gets back to my point about we have the Lego blocks. We have new distributions, Instacart and drone delivery. We have barcoding. If we had an enlightened health policy that incentivized folks to do healthy food, had the education with that technology, and I see some of those things actually out there in the digital health hall, that would be a wow. That would be a game changer when it came to childhood obesity and those kind of things.
Yeah.
So for me, I'm with Susan. So definitely the technology that brings with it the rich data and insights from the data. I'm optimistic that we'll get to a place where we're doing precision prevention, not just precision treatment for conditions like cancer like we do today. So I'm a very, very big believer in the power of data and what it can provide. And so it's not just data that's generated within a clinical setting or within an insurance company, but it's bringing everything together alongside the contextual data that helps us understand the social elements so that we can really make a difference and drive outcomes.
I am fascinated by all of the technology that is really consumer-centric and really having consumers engage in their healthcare, whether it's a digital diagnostic like a continuous glucose monitor, or it's some of the things that we've seen out here today in terms of fitness and sleep and testing your own urine and all these sorts of things. But I think, combining those things, I think a lot of these things have to have a care model and have to have a way of engaging members, like engaging patients, engaging consumers, to say who would use it. Because what's really very interesting is, like so many of these things, I'm sure everyone in this room is an early adopter. If I were to say how many people are tracking your own steps, you're probably all going to raise your hands. How many people have this? You'll all raise your hands. But the people who aren't early adopters, to start to get them to recognize, hey, I actually am in charge of my glucose. I actually can impact my diabetes. If I drink a soda, my sugar goes way up. If I walk around the block a few times, it goes down. They can see that behavior modification from that real-time feedback, biofeedback information. But what we have to do is we have to make it so that people, that's real personalized medicine where I'm going to engage in my healthcare. Because we can have a lot of tools, but if it's not something that I want to use or feel like I'm confident in using, I think that's the next step for you all to say, how can I make people engage? How can they feel confident? They can feel health literate. There's a game called EndeavorRx. I don't know if you all know about that. It's a digital game that was approved by the FDA, and it's for 8 to 12-year-olds who have ADHD. And it's really stimulating those parts of the brains to get people to, potentially have to be able to go off of their medication. So, I mean, these are the sorts of things where it's a gamification. I'm not saying you're going to gamify everything, but like if you can get that engagement, get people to feel confident, and that they actually do have some skin in the game, because it is hard for people to not just go home and eat the macaroni and cheese or the fast food or whatever, even if they aren't in a food desert. They're not always eating all the fruits and vegetables they should do. How can we, incentivize them and get them engaged in their health? I think that's a big place.
It gets back to your fragmentation point. The technology, the nerdiest and geekiest that I can be, I look at a situation where, this T-shirt is sending continuous data. So I don't have to think about it. I don't have to have my steps on my Apple Watch and this I'm here and I got to go home and do this. It's sending continuous data. And if I have atrial fibrillation, I know I'm not going to die in my sleep. Because literally, if my heartbeat goes above a certain thing, it's going to wake me up and send a note out to the ambulance. I mean, when you start to get that data together with making it easy and seamless, right? Like, again, getting back to finance, that's how it is in finance, right? If you overdraft your thing, right? You get a little note, you overdraft it. Do you want to transfer money from this account? You press one thing, you do that. Steve, your blood pressure just went up to 120/90. Can our nanotechnology go and give you a little bit more ditalazam? I mean, that's where we need to get to.
And do it for everybody, not just those that happen to like technology, that understand technology, but make it relevant to everybody, especially those that
their
need
homework
it.
assignment.
Yeah, there you go. So I'm going to give myself the chance to answer this question briefly, and then we'll have about 5 minutes for Q&A. I have to agree with the majority of the opinions. I think the data is extremely important, and I'll use an example. It doesn't matter my company or the therapy, but we have a therapy that if you give it to a patient with a certain disease, there's a 50-50 chance they'll use it. But if you give them a device that's connected so their doctor can see how they're doing, adherence jumps to 73%. If the patient downloads the app so they can see how they're doing, the adherence jumps to 86%. So we know digital health works. We know data and insights can drive and motivate people. So I have to agree. But I also want to say the answer about food technology is quite interesting. If you didn't get a chance to go to the opening keynote of this morning, the John Deere presentation was one of the best technological presentations I have ever seen. That is a company that is walking the walk. They are doing what a lot of companies say they want to do, and they are already doing it, and they build tractors for farmers. You would think healthcare would be difficult to digitize. This is a truly rural, agrarian, manual, centuries-old profession. And I'll tell you what, John Deere puts a lot of healthcare technology companies to shame with what they showed. So thank you all. We've got about 4.5 minutes for questions. If anybody wants to work their way up, there's a microphone there. There is a microphone there. We see we've already got one person.
My question's for Dr. Klasko, big fan of yours. I want to talk about the doctor side, the creation of the next generation of doctors. You were unique in admitting to medical college people with degrees in history or music and things like that. I'd be interested in your thinking on that. And also, how are we changing the education processes at the medical level with technology? And is the future degree, undergrad degree, since data is so important for medical colleges, is it a degree in math or physics or something like that?
You know what, I'm so glad you brought that up because it's the non-tech biggest problem we have. We still accept medical students based on science GPA, MedCats, and organic chemistry grades, and somehow we're just amazed that doctors aren't more empathetic, communicative, and creative, right? And so in essence, the way we choose, to your point, the way we choose medical students is that everybody's going to be a physician scientist at Yale. Not that there's anything wrong with physician scientists at Yale. But that's partly why we don't have people thinking about health disparities and that kind of thing. So we started the first medical school in the country at University of South Florida, where we erased all the objective criteria and chose students based on self-awareness, empathy, communication skills, and cultural competence. Just give you one quick example. We took them to an art museum, and there was a really abstract painting, a guy in a black turtleneck, woman in a white dress, and a snake. What do you see? I see a guy in a black turtleneck, a woman in a white dress, and a snake. Okay, yeah, but what are you feeling? What's the emotion? There are some applicants that couldn't get beyond what they see. There are other applicants that could tell the story. And you might say, Steve, why does that matter? I've delivered about 2,000 babies. It's pretty easy delivering an 8-pound baby to a normal 28-year-old. I mean, easy for me to say, I'm on the other end, but it's incredibly difficult delivering an unscheduled Down syndrome baby. And 100% of the time, the first question will be, doctor, what does it mean? I've watched good analytic obstetricians talk about the 21st chromosome or the medical complications. I've watched great obstetricians get the, what does it mean? What does that mean in my image of a perfect baby? And right away we'll say, this is a beautiful baby, I'll get you together with other people that have beautiful babies like that. The reason that's so important is there's a 100% chance there's going to be a Google Brain or something that will take a picture of that baby 10 years from now and tell me what's chromosomally wrong with it. So I don't care if you can memorize all that stuff, at least for that kind of physician. So yes, you're right. We need to look at, just like we need to look at technology differently, we need to look at the human factor in a very, very different way.
Look deeper.
We'll go to this mic next.
Hello. Thank you all for the talk and conversation. Really learned a lot. My name is Fritz Desir. I represent a venture studio in New York, and we essentially design startups and build them. And one of our focus areas is health and wellness. So curious to know, and I'm sure there's other people in the audience too, like one of the biggest blockers is for young companies that are creating things and coming at things in a sort of innovative, lean, tech-first way to actually get to you, like to actually be able to, have a sort of, a platform to say like, hey, this is what we're working on, so on. So curious to know, what would be like some advice that you could give, or if there are any official programs or anything that you have together, a demo day or anything like that, to look at, what people are creating to help solve for some of what you've mentioned up here. That's for the whole panel.
UHC does.
I'll take a stab at that. What basically, technology is really digital therapeutics, digital diagnostics, all those things. Some things are in the wellness space. But when what you're looking for is the customer, right? Like who is going to be the customer for you? And there's probably two customers. One are health systems that are doing care delivery. If you have something that's going to be used by physicians or hospitals, that would be on the care delivery side. If it's something that you think should be covered in a health benefit, that would be the health, payer side. And sometimes there's that wellness thing that would be directly to consumers, but then potentially also could be wellness for private employer groups who want to add a wellness benefit to their, to make sure that their employees are staying healthy, or they encourage their employees to stay healthy. So that can go a little bit across the wire. In any of these things, I think if you think about it, a little bit of a scientific approach and say you need to collect data. You have to have proof points. You have to get a population of people. And at Jefferson, we partnered with some, innovative startups, and we were able to use the populations at Jefferson of our employees for some, startups that you would know the name of now, and having an opportunity to use your technology as intended to say, is it actually working? And there's an article in JAMA. I just finished doing a ton of CME to renew my license at the end of the year. And it was an article in JAMA about all of the new behavioral health apps that are out there. And how does anybody grade how they're done? And there's a group that has actually put together a scoring system for them. And one of the scoring things where they gave additional points was if there was actually a controlled trial, any kind of published evidence in a peer-reviewed journal. Then you got other points if you had any kind of, it didn't have to be in a peer-reviewed journal. So I think it's really important to say, hey, I can show you that people will adopt my application. We've seen applications that have anywhere from 2% to 60% adoption. 60% is better than 2%. So when you to see, hey, how many people are going to engage in it? How many are going to continue to use it? I'm talking about like if it's a consumer, and then what kind of outcomes do you expect from that? That's the kind of thing that really talks, I think, not only to payers, but also to providers. Is that fair?
Now, I know we're out of time, but if we don't get the hook, I'll keep going for another minute or two. We'll start with this one here.
Sure. You mentioned trust was important. People will trust their health data to social media, but will not trust their health data to their clinicians. And I think a lot of that has to do with the fact that when a clinician speaks, it condemns them to pay money they may not have. So I asked the panel, how would you go about fixing the broken foundation of money in healthcare?
Do you have about 2 years? Can you guys stay here? Look, I think we're starting to see little snippets. This is like, like watching when there's a storm, watching the ice start to melt. Like in Medicare Advantage, you brought up. I mean, at Jefferson, we had an accountable care organization, and just the incentives were all wrong. We were actually partnering with Humana, and they bought 50% of that ACO. And it's one of the first things where the incentives for the patient, the provider, and the insurer are all aligned. The other thing that we underestimate is the whole issue of self-insured health system employees, right? I mean, we had 35,000 employees at Jefferson, right? If that's an area where we're aligned, if we can't figure that out, if our employees aren't healthy at a reasonable cost, then why would we think that I'm going to be able to do a contract with United on the commercial or Medicaid side that would work it out? So that's where we tried a lot of our new technology. And getting back to the question that the gentleman asked over here, if somebody came to me with a good idea, I'd say, okay, I'll tell you what, that's how we started with Livongo. Let's try it on my employees, because that's aligned. If it doesn't work there, where I'm the patient, the provider, and the employer, then it's not going to work anyplace else.
And then you'll have the last word, the last question that will generate the last word.
Thank you very much. My name is Tyler Tan, and I have one question for Dr. Raymond Tangela. So you mentioned that you are a big believer in preventive care, and I was wondering, from your perspective, what would be the future integration of preventive care and sick care?
That's a great question. I really hope that they blend. So today we talk of them as though they were two separate things. Like if you look at the healthcare system here, it is mostly geared towards sick care, like everybody alluded to. But when we talk of digital health, digital technology, and data, it should be just as much about keeping people healthy and preventing risk and disease from occurring as much as it is today about keeping somebody who's diagnosed healthy. So to me, they kind of go together, and I feel like whether it's a health system, a health plan, or a company like Teladoc Health, if we can do a good job taking care of those that are sick, we know what works. Because at the end of the day, you're talking lifestyle management, you're talking some fundamental things. You can take the same thing and apply it to people that are healthy today so that you can keep them healthy and prevent them from going the other way.
Yeah, and look, I think that's where technology and preventive health come together. On Saturday at 1 p.m., I'm going to be interviewing the CEO of Moderna and about their new cancer vaccine. And that you don't get more technology and science than that. But the future is going to be around how does preventive health and liquid tissue biopsies, and then sort of combining that with the technology of which vaccine do I need, before I get sick. So I think this personalized medicine, population health, technology, the human experience are all starting to come together as we start to get some of these payment models sort of figured out so we're not quite as fragmented, expensive, and inequitable. That's my optimistic way to end this, and hopefully that's what we'll start to see.
And Moderna vaccine that Dr. Klasko mentioned is a great example of how math was used on science to come up with the vaccine at a time that was necessary. So it was the partnership between Moderna and AWS. I happen to know because I worked at AWS. So that's how that vaccine was developed. It was not just a science exercise, it was the application of math on that. So thank you for the question.
Thank you.
Well, thank you. And thank you for letting us go over. And for those of you who stayed the extra few moments, this was a great discussion. Thank you to the panelists. I hope you enjoyed it and learned something. And enjoy the rest of the show.
Thank you.